Thank you so much. It's a great pleasure to be here. Thank you for having me back. I will have to cut the subject to focus only on some highlights, and the highlight of this talk will be TCAR. But before I start, let's take a step back. Is anyone recognizing this procedure? It's not Professor Matthias's procedure because there would not have been a stent there. This is Garvey Rubin procedure some 30 years ago. And you can see this is an absolutely perfect CAS by today's standards. This well could be a C-guard CAS. So they very quickly realized that this procedure has a huge potential in stroke prevention. What they also realized, and they early communicated, that improvements in technique, devices, and adjunctive therapies are necessary. After several years of evaluation of first-generation carotid artery stenting, this is what Kosmas Paraskevas and Frank Vieth wrote. There's a problem with plaque morphology. There's a higher incidence of microemboli and cerebrovascular events than in CA, not only during but also after procedure. So go away. But what they also said, come back when you have some new answers and new data. And like I said, they say, do come back if you have, once you have some better data. So today we not only have some better data, but we also have the evidence. This talk, like Chris's talk, is focused on the MicroNet-Covered Stent, an open cell device that is very, very well adaptable to the anatomy, and the device that now we know prevents plaque prolapse into the vessel. And there's nothing more beautiful to anyone who's doing carotid procedures than the beauty of flow reversal, that beauty of uncontrasted blood coming from the head to the bottom. The body of evidence is very large these days and very extensive, and of course I would have needed 8 times 5 minutes to take you through all those studies. Most of those studies are already completed, so let's just take some focuses. By the way, there's also randomized data, and there's also meta-analysis today. So this is an example from one of the studies that is coming out in the next few days. SimGuard study, true simultaneous MicroNet-Covered Stent, TCAR plus AVR plus CABG, urgent procedure in very complex patients. And I will draw your attention here to this sheath, a silk road sheath that is being placed from within the chest. This woman has a short neck, is a small lady, and this is part of a true hybrid procedure. This is now published. You can see the flow reversal and that element of the procedure. So now to TopGuard. TopGuard is a combination of TCAR and C-guard. We have joined forces with Isabel van Herzel and Ralph Kolvenbach, both in the audience, to do a study in 105 consecutive patients. These are elective cases, so not the kind of case I was showing before. I want you to know the high proportion of symptomatic patients and a high proportion of diabetic patients in this study, also thrombus-containing calcific and ulcerated lesions. This is an example of one of the procedures. You can see again an effective flow reversal, lesion pre-dilated, appropriately post-dilated. We believe it is very important to optimize those lesions, and the final angiographic result of a total endovascular here, in this case, with a surgical cut down to access the artery, total reconstruction of normal anatomy. These are the procedural data. Majority of procedures under local anesthesia, 69% pre-dilated, more than one stent to cover the lesion length in 3. Majority post-dilated, flow reversal time 6 minutes, 52 seconds on average, skin to skin 58 minutes, and flow maintained in majority of the external carotid arteries. These are some examples of those procedures with a DWI subset that we could only afford the initial phase of this study, so no or nearly no new hits. This is the results. If you look at the complications and follow-up data, so 2 TIAs, there was periprocedural confusion, 1 minor stroke. That was a procedural stroke. It occurred in our center. It was not the first patient, but patient 60-something. Stroke occurred during the insertion of the sheath with inadvertent lesion interrogation with a 0.35 wire, so really prior to the procedure. No death, no MI, total 30-day death stroke MI rate 0.95%, normal instant velocities. So now back to transfemoral procedures. We believe that this can also be done in majority of patients using the transfemoral using the transfemoral route. What is really important is to optimize, we believe, the stent, to appropriately post-dilate the stent, to embed it into the wall. Now there's 5-year data available that demonstrate normal healing of the device, no device-related issues. Again, I would like to stress the importance of coronary lag optimization, for which we have data from 2 other studies that I will not have time to go in detail with you through. However, as you can see, this is a series of 533 procedures in 500 patients. Again, very complex population, properly optimized stents with the 30-day death stroke MI rate of 0.94%, very good freedom from clinical events by 12 months, and freedom from any procedure or device-related issues. The randomized study is also there. The randomized study is powered for the DW MRI hits, and what it showed is a very profound reduction in cerebral embolism with MicroNet-Covered Stents. So we believe that this is the new standard and this is the future of carotid artery stenting, using either the endovascular route, totally endovascular route, or using, for those who prefer, go directly through the carotid artery using TCAR. Thank you so much for your attention.